I'm going to talk now about one of the non-VKA oral anticoagulants. Its name is dabigatran, and dabigatran is a direct thrombin inhibitor. It's different to the other non-VKA oral anticoagulants, which are factor Xa inhibitors. I want to start off by showing you the image that we saw in 2009 when the results of the RELY trial were shown at the European Society of Cardiology. And I was the discussant following this trial, and these were the images that did cause an audible gasp from a very, I would say, generally sophisticated audience. They had never expected to see results of this kind. And I put two graphs side by side. One is looking at the primary outcome of the RELY trial. I'm not going to talk in detail about these trials. I'm not going to give the designs and all that sort of thing because we haven't time today. I'm going to look at the primary outcome, which is stroke or systemic embolism. And we'll compare, for example, the result with warfarin with the result of one of two doses of dabigatran, in this case 110 milligrams twice a day, and in this case 150 milligrams twice a day. And you can see that there was a 34% relative risk reduction with dabigatran 150. This was statistically significant, obviously, and with dabigatran 110, that was not inferior to warfarin. There was actually a 9% reduction, but not significant. At the same time, the intracranial hemorrhage associated with either of these doses was very significantly reduced, in one case by 71%, in the other case by 59%. So in both instances, we had a reduction of thrombus and thromboembolism, and we had a reduction in the most feared consequence of bleeding. Now, no one had ever expected that we would see results like that. So that was what caused the gasp. Now, if we begin to dissect this trial, I'm not going to do this in detail, but I want to show you this result. This is looking at ischemic events that occurred when dabigatran was compared with warfarin. And you can see that in the case of dabigatran 150, there was a 24% reduction in these ischemic or unspecified strokes. Now, that is a unique result. It has not been seen with any of the other novel or non-VKA oral anticoagulants. So I think that we need to say that about dabigatran. Now, I also want us to look at more to do with the safety endpoints in the RELY trial and show you that for dabigatran 110 milligrams twice daily compared with warfarin, there was a substantial and a significant reduction in all forms of bleeding, including intracranial, which I've shown you, but major life-threatening and total bleeding. And with dabigatran 150, there was a reduction in life-threatening bleeding, total bleeding, and intracranial bleeding, but not a significant reduction in major bleeding. Gastrointestinal bleeding was increased with dabigatran compared with warfarin. The main reason usually advocated to explain that is because you have an active anticoagulant in the gut, as opposed to warfarin, which is not, when it's in the gut, an active anticoagulant. It has to have an effect on the production of coagulation factors to cause bleeding. So dabigatran, although a prodrug, is certainly converted enough to an active anticoagulant to cause both an increase in upper and lower GI bleeding. Now, I want to show the effect of age and bleeding in the RELY trial because this caused a major controversy on both sides of the Atlantic or across the Atlantic. You can see with dabigatran 110, as age goes up, the reduction in bleeding is evaporated. we can see that with dabigatran 150, exactly the same phenomenon occurs, but by the time we get to aged over 75 or more, there's a statistically significant increase in the bleeding rate. Now, this was the single finding that pushed the European Medicines Agency into licensing not only the 150 milligram dose, but also the 110 milligram dose. Interestingly, it was this finding that was totally ignored by the Americans when they decided they would license only 150 milligrams of dabigatran. Now, the Americans largely made their choice of dabigatran 150 on the basis of net clinical benefit. And we can see in this analysis of net clinical benefit that that benefit is greater with dabigatran 150, a reduction from 7.91 to 7.11, than it is with dabigatran 110 milligrams. And we can also see that with regard to stroke and systemic embolism, that 110 was non-inferior but not superior, and 150 was not only non-inferior but statistically superior to the warfarin comparator. And therefore, the Americans chose not to approve dabigatran 110 but to approve 150. Now, the first controversy that arose was whether the effect seen with dabigatran was due to poor control with regards to warfarin. You can imagine that if warfarin is not controlled well, a drug that doesn't depend on all the variation that is seen with warfarin might appear to do better, but that in patients who are well controlled, that effect may disappear. Well, here we see the trial centers divided into quartiles according to how well they kept patients in the therapeutic range. And this is the top quartile, the best group, that's the worst group. And we can see a hint of a reduction of the advantage associated with dabigatran disappearing as the highest quartile of good warfarin control is seen. Interestingly, this is not seen with any of the other novel oral anticoagulants, and importantly, it's not statistically significant with them, but nor is it statistically significant with dabigatran. This is the p-value for interaction. Now, let's have a look, however, at what is even more important, and this really sells the whole game. If we look at intracranial bleeding, and we do exactly the same analysis, let's say for dabigatran 150, just to save time, if we look at the quartiles of good warfarin control, and here's the best one, we can see that intracranial hemorrhage is reduced 61% in the best group of warfarin control when dabigatran 150 is used rather than warfarin. That really does seal the argument about whether dabigatran has advantages over warfarin. Now let's look at some of the other outcomes from the RELY trial. And the first one I'd like to look at is mortality. And we see with regards to mortality, let's just stick to the 150, that there is a statistically significant reduction in vascular, that could also be called cardiovascular events causing mortality, but that it's not quite significant when all-cause mortality is considered. We'll hear that some of the other novel oral anticoagulants have got significant reductions in all-cause mortality, but all of them are reducing all-cause mortality by about 10 or 11%. In some cases, the trials were just big enough to make them significant, and in others, not quite big enough. But here you can see the p-value equals 0.05. It's just not less than 0.05. And I think there's not much difference between these drugs. Now, the next controversy that arose with dabigatran was whether there is associated with this drug an excess in ischemic events. And here you see, for example, some revised figures that were published in the New England Journal of Medicine almost a year after the original figures from RELY. And you can see that there is a hazard ratio for myocardial infarction, in this case clinical and silent MI, and in this case for just clinical MI, of between 27 and 32%, but in neither case is it actually statistically significant. Now that was the conclusion from this trial. But the fact that zymalagatran, another direct thrombin inhibitor that preceded this one, also had an excess of myocardial infarction, had raised suspicion that this might be a real signal with regard to dabigatran. And so we then began to see meta-analyses of all the dabigatran trial data. And here's one such meta-analysis, this one from Uccino, and we can see that when he combined the results of all of these dabigatran trials, some of which are in AF, some are not in AF, you can see that the signal persists with a 31% excess, and we can see that this is statistically significant at the 3% level. And we can also see that if you vary the data and do a kind of sensitivity analysis, these signals also persist. Borderline, but they do persist. Now, Honloser then did another meta-analysis of dabigatran, which was quite interesting because he said, well, don't let's just look at myocardial infarction, whether it's clinically silent or whether it's clinically overt, but let's add other coronary events. Let's, for example, include cardiac death, cardiac arrest, or a composite of myocardial infarction, unstable angina, cardiac arrest, or cardiac death. And he showed that the more you included, other than just the myocardial infarctions, the signals seemed to disappear, and if anything, reverse, although there's no significance at all in these values. So his argument was that this signal really doesn't exist. Now, this was taken a bit further because it was possible with the RELY study to follow some of the patients out after they'd finished the trial if they continued to take dabigatran 110 or dabigatran 150 twice a day. And that study is called the Reliable study. And we often see some plots that look like this. This is the extension of the trial with some of the patients who came from the study. Obviously, the Americans were not included because they didn't have 110. And this is looking at all the trial together, starting the extension, adding the extension to the original trial. And you can see that as far as mortality concerned, there was no difference between 150 and 110 milligrams twice daily. And if you look at why this is, you can see stroke and systemic embolism was consistently and continued to be less with dabigatran 150 than 110. And that was true for the trial in combination as well as the Reliable data alone. But that bleeding events were more excessive in the dabigatran 150 than in the 110. Altogether, it neutralized and became very straightforwardly equal. And we can see that looking at the bleeding events in Reliable, that intracranial bleeding now followed for 4.5 or 5 years rather than just the couple of years in the trial, remain very significantly less with dabigatran than with warfarin, and you can see there's no difference of any sort, of any significance, with regard to the difference between the doses. And when we look at mortality, we see again that there's no difference between the doses of dabigatran, leading many to conclude that 110 milligrams daily might be a lot better than 150 milligrams daily. And this, of course, is an absolute contradistinction to the FDA position, because they decided 150 twice a day was much better than 110 twice a day. And the next problem that happened with dabigatran was we began to get lots of reports of uncontrolled bleeding and fatal hemorrhage due to the introduction of dabigatran. And here's a formal notification from the MHRA in this country to that effect. Immediately we had response from the company, Boehringer Ingelheim. They quickly put together all the reports of fatal hemorrhagic events that they had seen and compared that with what had been hemorrhagic events that had been seen in the trial in percentage terms or per 100,000 patient years, and showed that the real world data was, if anything, a lot less than seen in the trials. But of course we know that not everything in the real world is reported, so it's difficult really to compare these data with these data. But the consequence was that the health authorities really around the world put out data which was similar to this. They said, in view of these increase in hemorrhage, which was generally because the drug was given in too high a dose in patients who had poor renal function, they started saying that renal function had to be repeatedly assessed, and we now know that this is important for dosing of a drug like dabigatran. The FDA response was to set up a formal comparison between dabigatran and warfarin in what they called a mini Sentinel project. Now, the Sentinel project is a very large project that the FDA is running. They have lots of medical centers with electronic medical records. They have not only the primary care, but they have all the hospitals within any particular region. So they know every time a patient is started on a drug, when they're stopped on a drug, when they report any adverse events. And they know when they're admitted, when they have strokes, when they have bleeds, and so on and so forth. So it's a very comprehensive administrative database. So they decided to look at new starts of warfarin and new starts of dabigatran, and they concluded that dabigatran was no worse than warfarin. The figures, which I'll show you in a moment, actually persuade one that it's somewhat better with warfarin. And here are those figures. So we can see in dabigatran, as far as GI hemorrhage is concerned, 1.6 per 100,000 patient days, and with warfarin 3.5 per 100,000 patient days. And with regard to intracranial hemorrhage, as expected, 0.8 with dabigatran, 1/4 of the 2.4 with warfarin. So here was a conclusive statement from the regulators that this is not a problem. Well, the last thing we heard on that was these data that came from the AHA just a couple of weeks ago, when somebody produced a meta-analysis of the trials, looking at dabigatran and comparing it with warfarin, and looking at all of these trials, doing a meta-analysis and showing that there was a 40% excess signal of GI bleeding with dabigatran. So we're left now with the regulators saying there's no increase, if anything it's the other way around, and trial investigators saying there is a significant increase. And I think that they simply reflect the trial world and the real world. And probably there is little extra bleeding, but what there is not as bad as it would be on warfarin. Now, here we have some data looking at intracranial bleeding rates in patients who are treated with dabigatran, warfarin, aspirin, or no treatment, and we see warfarin is the larger problem. And here we have the stroke rate, and we see that no treatment, of course, is the worst problem, aspirin the next. Warfarin is relatively good, but dabigatran is much less. So lower intracranial hemorrhage and lower stroke rates. Now, coming on to the next problem, it is valve thrombosis, mechanical valve thrombosis with dabigatran. And here we see a gory picture of a thrombus on a mechanical valve. Here are a couple of case reports of people who were switched to dabigatran from warfarin after they'd had aortic or mitral valve replacement surgery, and they developed thrombosis. Because of this, it was decided to do a formal trial in patients who would be treated with dabigatran and had a mechanical prosthetic valve inserted either more or less immediately prior to randomization or in a second group more than 3 months prior to randomization. They were then randomized to a trial where the endpoint was largely to find an appropriate dosing level for what would be a subsequent trial. And you can see that when that was done, patients were treated with 150 BID up to 300 milligrams BID compared with warfarin, and they used the hemoclot test to work out what dabigatran levels were. The primary endpoint was the dabigatran concentration, and clinical outcomes were looked at. Unfortunately, the next thing we knew was a statement from appearing on heart.org that said the Realign trial had stopped, and it had stopped prematurely because people were having both thrombosis and hemorrhage when treated with dabigatran. And here you can see that there were 9 patients with dabigatran and no patients with warfarin in whom strokes occurred, and there was major bleeding in 7 with dabigatran and only 2 with warfarin. So this trial stopped prematurely, and I think it's put a stop to several other trials, although work continues in the experimental laboratory, and there's lots of suggestions that combining 10A and factor 2 inhibitors will actually be more effective than warfarin for valve thrombosis, but that neither drug alone is going to be sufficient. Now, just a word about cardioversion. Cardioversion's okay with dabigatran, at least we think it is. 1,800 cardioversions in RELY, 1,200 patients divided into 3 groups. The warfarin group and the 2 doses of dabigatran, and we see that the stroke and systemic embolism rate is about the same for all 3 limbs of the trial. We can see that for those patients who had a transesophageal echocardiogram, the stroke rate was less than those who did not. And because this trial was open with regard to warfarin versus dabigatran, more patients had a TEE if they were treated with dabigatran, which may subtly distort these results. But I think that many people are going ahead with cardioversion on dabigatran. If we look at ablation, we can also see that ablation procedures are going ahead on dabigatran, with dabigatran just stopped for the morning of the procedure, and we can see that there's very little difference between the 2. In fact, in meta-analysis, we see that as far as thromboembolic events is concerned, it's no worse, not statistically worse, with dabigatran compared with warfarin, and with major bleeding, there's absolutely no difference, and the same was largely true of minor bleeding with ablation procedures. Dabigatran is difficult to manage in the sense that you've got a choice between 2 doses or not giving it at all. It's important to work out if the patient is appropriate for dabigatran. We have a set series of labeled indications for the drug in the SMPC. It's not just patients at risk, it's these particular patients. If they are appropriate for dabigatran, you have to estimate the creatinine clearance. If it's less than 30 mils per minute, they shouldn't get dabigatran. If it's more than 50 mils per minute, you have to ask how old the patient is. If they're older than 80, they should get 110. If they're between 75 and 80 and have a high bleeding risk for assessment using the Hasbled score, for example, they need 110. If they're under 75, they can get 150 milligrams twice a day. If they have intermediate renal function, if the high bleeding risk, they should have 110. And if they don't have a high bleeding risk, 150. So it's a little bit complicated choosing the doses. And there are other factors to be borne in mind, such as PGP inhibition with verapamil or with dronedarone or with amiodarone and so on and so forth. Now, is this drug cost effective? The original investigators said in Canadian dollars it was certainly cost effective. It was not cost free, of course. Per quali, it would cost somewhere between about $4,000 and about $30,000, depending on the kind of assessment that was made. A recent cost efficacy analysis in heart in British pounds shows you that the actual cost per quali is about £5,000. Now, this is well within what is health economically feasible, But on the other hand, you have to remember there's about 1 million patients in this country treated with warfarin. If they all changed to a NOAC overnight, it would go from a drug cost, just thinking about drug cost, from about 3 or 4 pence a day to about 300 pence a day. Let's call it that anyway. 300 pounds, not 300 pounds a day, I'm sorry, £3 a day compared with 3 pence a day. If you multiply that out over 365 days and with 1 million patients, it's an extra £1 billion to the drug bill. Of course, there will be savings down the line, and you won't have to pay for monitoring and so on and so forth, but that's somebody else's budget, not yours. So the cost impact issues are important. And what is happening in the UK is that the introduction of these drugs is being stalled in order to compensate for that. So at that point, I'll finish. Thank you very much.